Hello YouTube, welcome to Dr. Vibes, a learning point. In this video, we will study about intestinal obstruction. So first, let us describe what intestinal obstruction is. So it is defined as the interference in the passage of intestinal contents, that is either food, liquids or gases, in the forward direction. Now, we move on to the classification of intestinal obstruction. 1 is based on whether there is any mechanical obstruction or not. If there is a mechanical obstruction or a tumor that comes in the intestine and that is the cause of the obstruction, we call it dynamic intestinal obstruction. Another cause can be when there is no mechanical tumor or any mechanical cause that is causing intestinal obstruction. That is called as a dynamic intestinal obstruction, and the example of such case is the ileus. Okay. In case of ileus, you get to see that there is no peristaltic movement or there is no visible peristalsis. Next, we move on to another classification of intestinal obstruction, that is small bowel obstruction or large bowel obstruction. Small intestine or small bowel has 3 parts, duodenum, jejunum and ileum, and large intestine or large bowel has 3 parts, cecum, colon and rectum. Colon again has ascending, transverse, descending and sigmoid colon. Now let us see the causes of small intestinal obstruction. 1. It can be due to the post-surgical adhesions. So there has been a surgery in the small bowel and there are some post-surgical adhesions, which is the most important and the most common cause of small bowel obstruction. Second, there can be hernia when the small bowel is the content of the hernial sac. So the small intestine has been obstructed inside the hernial sac. Third cause of intestinal obstruction are the inflammatory bowel diseases, specifically to mention the Crohn's disease over here. Then we have tuberculosis in small intestine and malignancy, which can also contribute to small intestinal obstruction. 6th point is intussusception, which is usually seen in case of children. 7th is ascariasis, when the ascarius has obstructed the small bowel. 8th point is the bezoars and the enteroliths. Now what are enteroliths? Enteroliths are the stone-like hardened stool which has obstructed the small bowel. Now, let us move on to the causes of large bowel obstruction. First, there can be colorectal malignancy. So, whatever is the part of the large bowel, there has been a malignancy in that. And usually the left bowel is more prone to malignancy than the right bowel. Second can be volvulus. There are 3 types of volvulus. The most common is the sigmoid, followed by cecal, and then is the transverse colon. Third reason is the diverticulitis. That means there has been outpouching in the large bowel and then infection in that outpouching, which is called as diverticulitis. Fourth again can be the inflammatory bowel diseases, either Crohn's or ulcerative colitis. 5th is the TB. 6th is the fecal impaction. A fecal matter has obstructed the large bowel, causing the obstruction. The 7th cause can be hernia. And the 8th cause of large bowel obstruction is radiation proctitis. Now we should move on to the cardinal features that a patient will present with intestinal obstruction. There are 4 cardinal features. 1 is obstipation, 2nd is vomiting, 3rd is pain, abdomen which is colicky in nature, and 4th is abdominal distension. Now obstipation is a condition when there is complete stoppage of passage of both stool and flatus. Okay, now there is a clinical condition given to you where there is a 26-year-old boy who has come to the emergency on a stretcher with a passage of greenish vomiting since last night. There is severe intermittent pain in the abdomen since 2 days, abdominal distension, and there has been some passage of stool on the previous day evening. Due to the physical examination, you see the pulse rate, the hydration status, and you ask about the urine output. Now, as the patient has come into the emergency, the first step would be to resuscitate the patient by giving IV fluids. You also make provisions of cannulation to give fluids, to give medications, and to take the blood for investigations. Now you go for the abdominal examination where you see distended abdomen, tympanic node in the abdomen, There is no rigidity, no tenderness, no rebound tenderness. If you do a per-rectal examination, you see rectal ballooning. If you auscultate the bowel to hear the bowel sounds, then the IPS, that is the interstitial peristaltic sounds, will increase. Okay. In case of imaging, you have to go for X-rays. There are specific features of both small bowel and large bowel obstruction that you can see in the X-rays. I will discuss that with you in the subsequent video. After the diagnosis has been made that yes, it is intestinal obstruction, we continue with our conservative management. That is JOL, COL, NOL. JOL is IV fluids. COL is you are monitoring the input and the output. And NOL, that is you have inserted the nasogastric tube for feeding the patient. Okay, after conservative management is done, that is the patient is resuscitated, you further move on to further conservative management, that is IV antibiotics, IV proton pump inhibitors and IV antiemetics. And then you take the patient for surgery. Now, one thing to note is that conservative management is tried in those patients only who do not have any features of strangulation. And what are the features of strangulation? They are tachycardia, out of proportion pain, hypotension, tenderness of the abdomen, a toxic look, and features of peritonitis. If any of these features of strangulation are present, we cannot wait for conservative management. We immediately take the patient to surgery. Now, for how long do we have to continue the conservative management? Maximum 48 hours, but usually if the patient does not improve after 24 hours, we take the patient for surgery. Now, next up is what kind of surgery would you like to do for intestinal obstruction? First, you have to do exploratory laparotomy, and then depending on the pathology, you can do either band adhesions or you can do resection and anastomosis if there is definite obstruction.